Bandyopadhyay. Dr. Dipanjan Bandyopadhyay is a MD Medicine and a Fellow in HIV Medicine from CMC Vellore. He is currently working as Professor and Head of Department of Medicine with the North Bengal Medical College, West Bengal. He is a member of the State AIDS Clinical Expert Panel and an external examiner to the Universities of Delhi, Ranchi, West Bengal University of Health Sciences, and Indira Gandhi National Open University, to name a few. He has worked as a medical superintendent cum vice principal, a joint nodal officer, ART center, and technical coordinator for HIV/AIDS in Medical College, Kolkata. His areas of interest include HIV basics, occupational exposures, and ART. We welcome you, sir, for today's session and request you to start the session.
Thank you, and good afternoon, everybody. I hope I'm audible to everybody.
Yes, sir.
Thank you. Can we have the first slide? The topic of discussion today afternoon is malignancies in HIV. As HIV practitioners, when we talk of HIV and HIV medicine, what we first think of is opportunistic infection. And this is what we have grown up with, that opportunistic infections are the bread and butter of an HIV practitioner. But as we become involved in HIV care, we find that cancers or malignancies are also important, and we shall see how much they're important in today's world. Number one, we know today that HIV-infected persons are at high risk of malignancies, and this risk increases exponentially as they go down the ladder of immunodeficiency. These malignancies can be virally induced malignancies, or they can be immunologically activated malignancies. We have traditionally divided these into AIDS-defining cancers and non-AIDS. The three more important of these entities fall under the heading of AIDS-defining cancers, which are high-grade non-Hodgkin's lymphoma, invasive cervical cancer, and Corposis Sarcoma. The next slide. We begin with the most common of these, which we encounter in our clinical practice, which are AIDS-related non-Hodgkin's lymphoma. Now, across the board of HIV infection, there is a significantly increased risk of AIDS-related non-Hodgkin's lymphoma. And this is often a first diagnosis of an AIDS-defining illness. They are related to older age, low CD4 count, and especially are seen in ARP-naive individuals. What are the clinical characteristics of these cancers? They come in all forms and shapes, but usually present with advanced clinical stage. There are B symptoms in the form of weight loss, fever, and night sweats. And often they have extranodal manifestations, which we shall be seeing over the next couple of minutes. The next slide, Shweta. Now, there has been an effort of dividing these into lymphomas, which can also occur in immunocompetent persons, and lymphomas which are seen more specifically in the HIV-infected population. Those which can occur in immunocompetent persons are Burkitt's lymphoma, diffuse large B-cell lymphoma, which is usually high-grade, Hodgkin's lymphoma, and other lymphomas like Multomas. Those which are seen classically in association with HIV are primary effusion lymphomas, plasmablastic lymphoma, which, as the name suggests, is a more primitive and more aggressive form of non-Hodgkin's lymphoma. Lymphoma arising in human herpes virus infected individuals, which presents as multicentric Castlevania disease, We have learnt of Castlevania disease in the differential diagnosis of generalized lymphadenopathy. Lymphoma occurring in other immunodeficiency states like primary immunodeficiencies and polymorphic lymphoid proliferation, which resembles post-transplant lymphoproliferative disorders. Now, without getting into the technicalities, we will see how they impact the HIV-infected population and how we handle them best. The next slide, please. I was talking about virally mediated malignancies. And when it comes to non-Hodgkin's lymphoma, several of these are seen in association with Epstein-Barr virus. We know that Epstein-Barr virus was classically associated with nasopharyngeal carcinoma in our undergraduate ENT teaching. And today we know that diffuse large B-cell lymphoma, Burkitt's lymphoma, primary fusion lymphoma, primary CNS lymphoma, plasmablastic lymphoma, and Hodgkin's lymphoma, all these are associated with Epstein-Barr virus infection and sometimes with human herpes virus type 8 infection, which is more seen in multicentric Castlevania disease. The next slide. Now, coming to diffuse large B-cell lymphoma, this is the most frequent AIDS-related lymphoma. As we have already mentioned, and it is important to repeat, they come in the form of advanced clinical stage, more B symptoms and more extranodal involvement. You have lymphomatous deposits in extranodal sites. Low CD4 counts predicts a poor survival. They are treated with the traditional CHOP regimen, usually with addition of rituximab, and they are also treated with dose-adjusted R-epoch regimen. Now, the R-epoch regimen is a more aggressive cancer regimen, and we will not get into the details of chemotherapy because chemotherapy is generally out of the domain of the HIV treating physician or for our medical officers of the ART center. But it is important that we at least know the names of the regimens which are traditionally used and which have been upgraded in today's world. Now, dose adjustment is required because we are dealing with immunodeficient populations, and when we use chemotherapeutic agents, we face neutropenias, and once the absolute neutrophil count comes down to a critical level, we need to adjust the dose so that we minimize this hematopoietic toxicity of the chemotherapeutic regimen. The next slide. This was one of our very interesting publication from Medical College Kolkata, where we had a short series of plasmablastic lymphoma. And as the name suggests, these are very high-grade malignancies. And you can see on the left-hand side, you have a CT scan, which there is a large pelvic mass. And this large pelvic mass was causing ureteric obstruction. We impairment. There was obstructive uropathy. And on the right-hand side, you see the sheets of monomorphic cells. And they are all cells which are classically high-grade lymphomatous cells. So this was, and we have other patients in this series. One I remember was a patient of proptosis. So he had a retroorbital deposit of lymphoma. And again, these were classical extranodal presentations. So atypical sites, atypical presentations, aggressive cancers, these are the hallmarks of AIDS-related lymphomas. The next slide. Now, there are some oncologic terms in terms of response to therapy, and ideally, we should have a PET scan to look at what is the impact of chemotherapy on these cancers. So you can have a complete remission where the PET scan will be negative and there will be complete clinical and radiological disappearance of disease. You can have a partial response where the disappearance is more than 50%, but the PET positivity remains. You can have a stable disease where you do not achieve either complete or partial remission, or we can have a relapse disease or a progressive disease where we find new lesions or increase by more than 50% of a previously involved lesion. So these are standard chemotherapeutic terms or oncologic terms which we should be associated or accustomed to use when we deal with malignancies in HIV. The next slide. Now the recommendations, and the recommendation basically comes from the updated British HIV guidelines. We at NACO are in the process of bringing out the national HIV guidelines, and these recommendations will be reflected in our national guidelines as well. That chemotherapy should be combined with antiretroviral therapy. Regimen should either be R-CHOP, or if the lesion is more malignant or with more malignant potential, more aggressive cancers, we use dose-adjusted R-EPOCH regimen. Relapse or refractory disease should ideally be considered for bone marrow transplant, which is known as autologous stem cell transplant, after high-dose chemotherapy, and a PET scan should be performed at the end of chemotherapy and after 4 to 6 weeks of end of chemotherapy to assess for the clinical, radiological, and pathological response to the treatment. The next slide. After diffuse large B-cell lymphomas, Burkitt's lymphoma is the second commonest subtype of AIDS-related lymphomas. Now, we all know that Burkitt's lymphoma classically associated with the African subcontinent, but Burkitt's lymphoma in HIV can occur with relatively preserved CD4 counts. They have a poor performance status. There's a Karnofsky scale and high LDH count. Extranodal involvement again is common. Incidence of CNS involvement can be to the tune of 1/4, and risk stratification system exists where we decide on the aggressiveness of the chemotherapy that we propose to institute. The next slide. The risk stratification, as I said, can divide the disease into a low-risk disease or a high-risk disease. A low-risk disease must have at least 3 of these factors: a normal LDH, stage 1 or 2 disease. As we know, we classify lymphomas into 4 stages, a WHO performance score of either 0 to 1, and number of extranodal sites, maximally 1, 0 or 1 number of extranodal sites. The person satisfying 3 of these 4 criteria will be classified as low-risk disease. Now, who classifies as high-risk disease? If you have 2 or more of raised LDH, stage 3 or 4 disease, a WHO performance score of more than 1, and number of extranodal sites more than 1. So 2 or more of these will go as high-risk disease, 3 or more of the above will go as low-risk disease. The next slide. Now, Burkitt's lymphoma demands more aggressive, more cytotoxic chemotherapeutic regimens. I wish and I propose not to get into the details of the chemotherapy agents, but then the 2 regimens that goes hand in hand with the treatment of Burkitt's lymphoma in HIV are the Codox-M regime and the IVAC regime. And these 2 regimens are used alternatively. They are used in cyclic fashion. So cycle 1 and 3 will be, say, Codox-M, cycle 2 and 4 will be IVAC. And if you have a high-risk disease, you will need more number of cycles. And if you have a low-risk disease, you will require less number of cycles. So that is basically the philosophy of treating HIV-associated Burkitt's lymphoma. There is a substantial chance of treatment-related toxicity and treatment-related death. And we might choose the dose-adjusted EPOCH regimen along with rituximab, which is the dose-adjusted R-EPOCH regimen that we were talking about, which is much less cytotoxic if we have patients who are unlikely to tolerate the highly aggressive Codox-M vis-a-vis the IVAC regime. So going back and revising ourselves, first regimen, R-CHOP, second regimen, dose-adjusted R-EPOCH, traditionally used for the diffuse large B-cell lymphomas, the Codox-M and IVAC for the Burkitt's lymphoma, traditionally used either less number of cycles for the low-risk disease, more number of cycles for high-risk disease, and we can switch one to the other as our clinical judgment or clinical condition demands. The next slide. We were talking of CNS lymphomas. Now, primary CNS lymphoma is a very distinct entity in HIV medicine, but there can be secondary CNS lymphomas. And prevention of secondary CNS lymphoma is also an important therapeutic target. 25% CNS involvement by systemic non-Hodgkin lymphoma and HIV, advanced stage, elevated serum LDH, more extensive extranodal disease, and involvement of organs like testis, the paranasal sinuses, paraspinal involvement of organs like breast, kidney, the epidural space, bone. These predict a higher likelihood of CNS relapse. And for CNS relapse prophylaxis, we can use intrathecal methotrexate and or intrathecal araminoside C, which are reserved for those who deserve. Now, all patients with diffuse large B-cell lymphoma and Burkitt's lymphoma and HIV actually should be given intrathecal prophylaxis, because all patients with diffuse large B-cell lymphoma and Burkitt's lymphoma are at an increased risk of developing secondary CNS involvement. The next slide. For relapse or refractory AIDS-related lymphomas, aggressive regimens mostly containing platinum. Now, platinum or cisplatin-containing regimens are even a step forward in terms of aggressiveness and in terms of cytotoxicity. They are usually combined with rituximab, and the guideline recommendations are those who are fit for intensive chemotherapy should receive a second-line regimen which might or should contain a platinum-derived agent, and those who achieve complete remission or partial remission with second-line chemotherapy should be considered for autologous stem cell transplant or bone marrow transplant. So basically for you and me, as HIV treating persons and not as trained oncologists, we need to remember the basic recommendations that those who are fit for intensive chemotherapy should receive a second-line chemotherapy if the disease relapses or the disease is refractory to treatment or there is progression of disease despite a first-line chemotherapeutic agent. And once there is a response, either complete response or partial response to a second-line chemotherapeutic agent, we should consider the patient for bone marrow transplant in dedicated centers. So bone marrow transplant and even second-line chemotherapy should not be given in the general medicine or general HIV setting. It should ideally be given in oncology centers and especially in dedicated centers with experience in handling HIV-associated malignancies. The next slide. Coming to where we were talking about, primary CNS lymphoma, it is a subtype of diffuse large B-cell lymphoma confined to the craniospinal axis without systemic involvement. So when you have a primary CNS lymphoma, you will have a patient without lymphadenopathy. So you will not have palpable lymphadenopathy on clinical examination. You will not have lymphadenopathy on a chest X-ray in mediastinal winding or retroperitoneal lymph nodes on USG or CT scan. You can have a subacute focal features, and you can have neurological manifestations in the form of focal neurodeficits. You can have increased intracranial pressure in the form of vomiting and altered sensorium. And more subtle, you can have neuropsychiatric manifestations. So primary CNS lymphoma can come in all forms in the domain of clinical presentations. Theoretically, you need a stereotactic brain biopsy. Technically or clinically, we do not have access to stereotactic brain biopsy very easily. So what do? We have classical neuroimaging features, which I think I will share with you on a subsequent slide. And we have combination of detectable Epstein-Barr virus nucleic acid material in CSF, along with consistent radiological findings in severely immunosuppressed individuals, and we combine these information to arrive at a working diagnosis of primary CNS lymphoma. High-dose methotrexate containing chemotherapy regimen in continuation with ART, whole brain radiotherapy is a palliative treatment modality, and alternative first-line treatments are unacceptable risks of toxicity. So what are the recommendations? Basically, whatever chemotherapeutic agent we wish to use, there should be a methotrexate containing chemotherapeutic agent, number one. Number two, patients who are too sick to tolerate chemotherapy may be eligible for whole brain radiotherapy or irradiation. So this is palliative care, and alternative first-line treatments are unacceptable because of the high risk of toxicity. So what do? If we suspect a patient of primary CNS lymphoma or CT scan or MRI, number one, we should think of the other intracerebral space-occupying lesions. What are the other CNS pathologies that can happen in the HIV setting? And when we do the CSF analysis, we should do PCR for EBV. So Epstein-Barr virus PCR, if positive, will help us to achieve a working diagnosis of primary CNS lymphoma. The next slide. This is a very classical case, which is from my medicine ward of North Bengal Medical College. And here we can see a large space-occupying lesion, which is hyperintense on T2 imaging, and it is abutting on the ventricles. So what are the features which goes in favor of primary CNS lymphoma? You can have single or multiple lesions which are non-enhancing. There is a hyperintensity on T2 or flare images. They are densely enhancing masses after administration of gadolinium. And very interestingly, very clinically appropriate, more than 50% of the mass will be in contact with the meninges. And meningeal enhancement appears in 10 to 20%. So what I teach my colleagues, my students and juniors, is if you have a asymmetrical intracerebral space-occupying lesion, which is hyperintense on T2, abutting on the ventricles, a parameningeal location, abutting on the meninges, think of primary CNS lymphoma and send your CSF sample for Epstein-Barr virus PCR. The next slide. What are the other, before we move on to the domain of primary diffuse lymphoma, what are the other intracerebral space-occupying lesions that we need to remember? It can be a tuberculoma, which again, I keep on reminding myself that tuberculoma is basically an immune reaction. So tuberculoma should ideally be seen in the setting of good CD4 counts. In low CD4 counts, you can have disseminated tuberculosis, but not tuberculoma per se, unless it is an immune reconstitution syndrome. You can have a brain abscess, and the most common intracerebral space-occupying lesion in HIV is CNS toxoplasmosis. Now, CNS toxoplasmosis will not be abutting on the ventricle generally. It will be more bilateral, more the asymmetrical but bilateral involvement, more commonly multifocal. And if you do the CSF analysis, your IgG, anti-toxoplasma IgG, will be highly positive. What is primary diffuse lymphoma? Primary diffuse lymphoma is a rare B-cell lymphoma seen in severely immunosuppressed conditions with low CD4 counts. There are multiple effusions in the body, pleural, pericardial, peritoneal. Most importantly, without identifiable tumor mass or lymphadenopathy. So there will be no solid tumor mass or no lymph node involvement. It will only be multiple effusions. And most primary diffuse lymphomas have lymphocyte activation markers. I refuse to be dragged into the domain of CD4 markers because these come under the domain of oncopathology. Those who are interested, they can have a look at the CD4, the CD markers, which are the classical B markers and the T markers. But in primary effusion lymphoma, if you just note the fourth bullet point, the cells will not have the normal B cell markers or T cell markers. What does this suggest? That this suggests that they are more primitive cells. And more primitive the cells, more aggressive is the tumor. What is again interesting? The positivity in terms of HHV8 or human herpes virus type 8 positivity is almost 100%. So primary CNS lymphoma, we were talking of Epstein-Barr virus positivity. Primary effusion lymphoma, we are talking of HHV8 positivity. And immunohistochemistry for latency-associated nuclear antigen, we will not remember this, but just to note that latency-associated nuclear antigen is positive in malignancies which are human herpes virus 8 mediated. The next slide, please. Recommendations: in the absence of any standard treatment, primary effusion lymphoma and HIV should be treated with a standard CHOP regimen. The CHOP regimen is the age-old gold standard for the treatment of non-Hodgkin's lymphoma. Such treatment should be included as part of a clinical trial if possible. Why? Because there is an absence of any standard treatment protocol, and ART should be administered concurrently with such treatment. So that's primary effusion lymphoma for you and me. The next slide, please. Plasmablastic lymphoma. It is basically an aggressive version of DLBCL or diffuse large B-cell lymphoma. They can be mucosal, usually mucosal sites of involvement. There can be several histological types, and I told you it will be foolish for me to be dragged into the domain of histopathology and immunohistochemistry. But then there can be more primitive types in the form of plasmablastic types and more differentiated types, which are plasmacytic differentiation. More plasmacytic differentiation will involve extraoral sites, and plasmablastic lymphoma will involve more nodes or spleen associated with Castlevania disease. We will come to Castlevania disease in a short while. The next slide. Again, immunohistochemistry, they will be positive for plasma cell markers, which are the primitive markers, and they are consistently associated with Epstein-Barr virus, as we mentioned, and extranodal, extramedullary. These are all clinical variants of plasmablastic lymphoma. As I told you in our series, we had retroperitoneal deposits, we had retroorbital deposits, we had a patient who presented as a sarcoma of the thigh and ultimately turned out to be a plasmablastic lymphoma involving the skeletal muscles of the thigh. So that is the degree of clinical variation you see in lymphomas in HIV. The next slide. Recommendations: plasmablastic lymphoma CHOP regimen, follow-up radiotherapy, and most importantly, autologous stem cell transplant for more advanced disease. Above all, concurrent antiretroviral therapy. So now I think we're getting a feel of what our hang of what is the approach to the treatment of these AIDS-related lymphomas. The next slide. Corposis sarcoma. Now, Corposis sarcoma, we have traditionally learned and we have also experienced during our clinical journey of HIV that it is a rare cancer so far as the Indian population is concerned. So when we talk of the Indian or the Southeast Asian HIV population, we don't see much of Corposis sarcoma. They are basically vascular tumors. They come in the form of fleshy nodal masses. They are more common in the lower extremities. They can also involve the face and genitalia. They can be pink, red, purple, or brown. As I said, the diagnosis is based on the characteristic clinical appearance of cutaneous or mucosal lesions, but histological confirmation is essential. Histopathological grading classifies Corposis sarcoma into a patch or an elevated plaque or a nodule. The next slide. Corposis sarcoma lesions can be widespread. They can be edematous. They can ulcerate. Extensive oral corposis sarcoma lesions have been seen involving the mouth, besides the oral cavity, involving the hard palate, and there can be palatal perforations. Lesions of corposis sarcoma in organs other than lymph nodes, such as the lungs, presenting as hemoptysis, intestinal GI tract presenting as hematemesis. You can have liver SOL, etc. Corposis sarcoma in the lung sometimes means a worse prognosis. We have seen patients with massive hemoptysis, and we suspect that we have missed cases of pulmonary corposis sarcoma. The next slide. A very old photograph. Many of you have seen this photograph from our NACO presentations earlier, but this is how corposis sarcoma traditionally or classically appears as fleshy, vascular masses in the skin. But as I mentioned, they can be only mucosal, and there might not be any cutaneous involvement at all. The next slide. Recommendations: local radiotherapy or intralesional vinblastine for symptomatic or cosmetic improvement if you detect in early stages. Chemotherapy along with antiretroviral therapy for advanced stage corposis sarcoma. The liposomal anthracyclines in the form of doxorubicin and daunorubicin, they are the first-line chemotherapeutic agents, and paclitaxel can be used for anthracycline refractory corposis sarcoma. So again, for you and me, it is basically a clinical diagnosis. We require a histopathological confirmation, and once we have a histopathological confirmation, we need an oncological support. We need an medical oncology referral, and we might treat the low-grade lesions or early lesions or resistant or less widespread lesions with intralesional vinblastine. But if the lesions are more widespread, we need systemic chemotherapy. The next slide. The third and the most important AIDS-defining cancers is invasive cervical cancer. Now, let us remember, cervical intraepithelial neoplasia is the early stage of cervical cancer, and as it progresses, it reaches a stage of invasive cervical cancer. So in the clinical setting, when we talk of invasive cervical cancer, it is wise to encompass both cervical intraepithelial neoplasia and invasive cervical cancer together. Common in HIV, earlier age of diagnosis with respect to the non-HIV population, aggressive course and poor treatment outcomes. Most important is the co-infection with human papillomavirus. So cervicovaginal human papillomavirus infection is much higher in HIV than HIV-negative females. 2-yearly testing for cervical smear is sufficiently sensitive for cervical surveillance in PL-HIV. Antiretroviral therapy has had minimal effect on the incidence of invasive cervical cancer, but has effectively brought down the incidence of cervical intraepithelial neoplasia in women with HIV. Very interesting. So we have a beneficial effect of antiretroviral therapy on the incidence of cervical intraepithelial neoplasia in women with HIV. The next slide. Treatment includes surgery, early stages, followed by radiotherapy or chemoradiotherapy, surgery including radical hysterectomy and lymphadenectomy. Treatment of locally advanced cervical cancer includes radiotherapy, which can be external radiotherapy or brachytherapy, along with chemotherapy. The recommendations are screening cytology for HIV-positive women is recommended at the time of HIV diagnosis and annually thereafter. Very important. And I think you and me often miss this point. If 3 annual Pap smears are negative, we might be more lenient and it should be repeated every 3 years thereafter. Colposcopy, which is basically a cervical examination, should be performed by the gynecologist if abnormalities are seen on the Pap screening. Treatment of cervical intraepithelial neoplasia or invasive cervical cancer should follow the same guidelines as those advocated for the HIV negative population. And countries have very strong, very stringent treatment protocols, screening and treatment protocols for cervical cancers. The government of India has its own treatment protocol, and the treatment offered to the HIV infected population should be no different than from the HIV non-infected population. The next slide, please. Very similar to the cervical cancer story is the story of anal cancer. Now, anal cancer is not an AIDS-defining cancer, but one of the most important non-AIDS defining cancers. It is hugely higher in HIV-infected persons than the non-HIV infected, much younger age of diagnosis, highest risk in men who have sex with men, more common in those who have penetrative anal sex, rectal bleeding and anal pain or proctalgia are the usual clinical presentations. There can be fecal incontinence if the anal sphincter is affected. Pathogenesis, as I said, resembles cervical cancer with human papillomavirus infection leading to anal intraepithelial neoplasia and ensuing progression from low-grade to high-grade dysplasia and ultimately to invasive anal cancer. So what are the stages of progression? You have anal intraepithelial neoplasia, you have low-grade dysplasia, high-grade dysplasia, and finally, you move on to the domain of invasive anal cancers. The next slide, Shweta. So, histopathological grading of anal intraepithelial neoplasia. Now, anal intraepithelial neoplasia itself can be graded into low-grade squamous intraepithelial lesion, high-grade squamous epithelial lesion, and this can be further graded into the lower third of the anus, lower two-thirds of the anus, and the entire epithelium of the anus. So you have a histopathological grading of anal intraepithelial neoplasia. The next slide, which is a continuation of this slide, is classification of anal cytology. And for those who are interested, the Bethesda system is a system of cytological reporting when you report an oncology specimen from the pathology department. So Bethesda system basically tries to rationalize or systematize or make bring about a uniformity in the reporting format of oncopathology reporting. So here in anal cytology, you can have a normal cytology, you can have atypical squamous cells of undetermined significance, atypical squamous cells which you cannot exclude high-grade squamous intraepithelial lesions. Then you have the low-grade squamous intraepithelial lesion, high-grade squamous intraepithelial lesion, and ultimately, as we said, anal cancer, which is a squamous cell carcinoma. So, atypical squamous cells of undetermined significance basically means that you cannot prove pathologically that it is malignant, but you need to monitor and follow up the patient very, very stringently because you have a very strong suspicion that he is or she is in the process of progressing into squamous intraepithelial lesions. The next slide, please. Recommendations. All suspected cases of anal cancer should have examination and anesthesia and a biopsy. Who are the suspected cases? Rectal bleeding, anal pain, and fecal incontinence. Apart from this, men who have sex with men and history of anal intercourse. CT scan and MRI, especially I would suggest MRI, is more effective or more capable of assessing local extension and involvement of regional lymph nodes. High resolution anoscopy services for surveillance, combination radiotherapy or chemoradiotherapy with 5-fluorouracil and MMC is the first line treatment along with antiretroviral therapy and opportunistic infection prophylaxis, which is standard, salvage surgery for locoregional persistence or relapse. Best supportive care should be advised for metastatic disease or local relapse following salvage surgery. What is the bottom line of this slide? Number one, high degree of suspicion. Number two, anoscopy services. Number three, have radiological services in the form of MRI. That is the diagnostic part. Once you diagnose, you have chemoradiotherapy to offer the patient. If the patient doesn't respond or relapse or progresses, salvage surgery. And if the patient relapses following salvage surgery, all you can offer is best supportive care or palliative care. So that is a summary of recommendations for anal cancer in HIV. The next slide, please. Hodgkin's lymphoma, one of the commonest tumors amongst the non-age-defining malignancies, 10 to 20 times increased incidence in HIV-infected persons, more commonly at low CD4 counts. Interestingly, the risk of Hodgkin's lymphoma remains while the patient is on antiretroviral therapy, and predominance of mixed cellularity and lymphocyte depleted types as opposed to nodular sclerosis histology and a higher percentage of EBV positivity. So in the normal or the non-HIV infected population, we have more of nodular sclerosis and lymphocyte predominant. In the HIV infected populations, coming to Hodgkin's lymphoma, you have more mixed cellularity and more lymphocyte depleted subtypes. And as in the case of non-Hodgkin's lymphoma, you have a higher percentage of Epstein-Barr virus association. The next slide. We have the traditional Ann Arbor classification. I will not get into the details of this. And it is the same, the 4 stages of Hodgkin's disease. The stage 4 being involvement of extranodal sites. Stage 3 being involvement of lymph node groups on either sides of the diaphragm. You have bulky disease in the form of X. You have extranodal extension in the form of E. And you have B symptoms, absence or presence of B symptoms, which is weight loss, more than 10%, fever, and drenching night sweats. The next slide. Recommendations, ABVD, which basically translates into adriamycin, bleomycin, vincristine, and dacarbazine, is a first-line treatment administered with involved field radiotherapy. So you have IFRT, which is a radiotherapy only to the involved field. Good performance status, good performance patients with relapsed or refractory Hodgkin's lymphoma should receive salvage therapy. Salvage therapy is basically high-dose therapy and more toxic chemotherapy, but then they should also proceed for autologous stem cell transplant or bone marrow transplant. ART should continue, and you should give infection prophylaxis for PCT and even Mycobacterium avium intracellular prophylaxis. Response assessment, as we said, PET scan and maybe a bone marrow biopsy because there can be bone marrow relapse, and follow-up should be performed every 2 to 4 months during the first 2 years and 3 to 6 months for 3 years or further. Basically, what is the recommendation? The summary of the recommendations: number 1, ABVD. Number 2, if there is a relapse, you treat with high-dose therapy, more toxic chemotherapy, but consider the patient for bone marrow transplant. In the meanwhile, continue ART and continue stringent infection prophylaxis. And follow-up should include a PET scan, and follow-up should be more frequent in the first 2 years and less frequent for the subsequent 3 years. The next slide. Castlevania disease. This is basically a rare entity. It is a histopathological entity. We will not get into the details of Castlevania disease. It can be unicentric, multicentric. It is usually human herpes virus driven, and it can be a presentation of the Poem syndrome, which, as we learned, polyneuropathy, organomegaly, endocrinopathy, and monoclonal plasma cell disorder with skin changes. So a multicentric Castlevania disease is basically associated with HIV, and if we have a patient whose lymphadenopathy reveals Castlevania disease. I think the message from this slide is think in terms of HIV. And if you are sending a slide for histopathology in a HIV, from an HIV infected patient, you should keep your eyes and ears open for the probability of Castlevania disease and even the Poem syndrome. The next slide. So multicentric Castlevania disease is relatively rare lymphoproliferative disorders. There are very characteristic lymph node signs, but as we mentioned, because it is associated with human herpes virus type 8, there is expression of the latent nuclear antigen, which I said is a marker of HIV-8 infection, and these plasma blasts are generally polyclonal. So you have, and the next slide. The recommendations are you need a histological confirmation, you need monitoring because there is a risk of progression to lymphoma. Rituximab is the first-line chemotherapy, retreatment with rituximab-based therapy for relapsed multicentric Castlevania disease, and plasma HIV-8 levels can predict relapse, and clinical monitoring for patients in remission should include measurement of blood HIV-8 levels. I don't know how much this is possible in our clinical practice. I think the clinical information or the clinical message that we should take home from this last 2 or 3 slides is that multicentric Castlevania disease is a HIV-associated malignancy. It is significantly associated with human herpes virus 8 co-infection. Rituximab is the drug of choice, and it runs the risk of progression to aggressive lymphoma. I think that is a summary of what we should remember when we talk of Castlevania disease in HIV. The next slide. Coming to a few other residual cancers, which are also seen with increased frequency in the domain of HIV infection, seminoma and not the non-seminoma germ cell tumors occurs more frequently in HIV infection. So you need to remember the degree of a testicular mass. It can be orchitis, but it can also be a lymphomatous deposit. Now remember, when we talk of extranodal lymphomas, these extranodal lymphomas can be found in several organs. We talk of adrenal deposits. There can be, just now we talked of Corposis Sarcoma involving the lungs or the GI tract, and we can also have lymphomatous deposits in the testis, which can give rise to a testicular mass or a testicular swelling, apart from the usual orchitis, which can present with pain, fever, and tenderness of the testicles. So a seminoma can be associated with HIV infection. CT scan of the chest, abdomen, and pelvis should be performed because there can be distant metastasis, and seminomas have a tendency or a preponderance of clinically silent distant metastasis. Recommendations: surveillance for seminoma of testis in PL-HIV, concomitant ART and infection prophylaxis. Germ cell tumors of the testis should be treated in an identical manner regardless of the HIV status. And only point of concern or only point to note is that bleomycin may be avoided in the management of testicular germ cell tumors in HIV because of significant interactions with antiretroviral therapy. The next slide. We classify lung cancers into non-small cell and small cell lung cancer. This is age-old traditional histopathological classification. And we all know that non-small cell lung cancers are the common types of lung cancers. And now we know that there is a higher frequency of non-small cell lung cancers in HIV, presenting at a younger age and presenting with more advanced disease in the setting of HIV. Wide spectrum of infectious differentials of a lung mass in HIV. They should be remembered. It can begin with tuberculosis. It can be atypical mycobacteria or non-tuberculous mycobacteria involving the lung. It can be a lung abscess. It can be pulmonary nocardiosis, which can present as a shadow or a radiological shadow in the lungs. So we need to remember the differentials. But operable lung cancer, the treatment is curative surgery, localized advanced disease, where it's chemoirradiation. Just a point to note, EGFR or epidermal growth factor receptor is a marker of lung cancer aggressiveness. You can have testing for laboratory testing for EGFR mutations, and EGFR targeting tyrosine kinase inhibitors such as erlotinib and gefitinib are now available. So if you can document the EGFR mutation, you can use specific tyrosine kinase inhibitors directed at these mutant variants. So you can have more refined chemotherapy. The message, I think, is that if your oncology friend suggests EGFR mutation, you should at least understand why the EGFR mutation is being called for. The next slide. Before I move on to hepatocellular carcinoma, just a point on lung cancer. There are several confounding variables or confounding factors which can predispose to lung cancers in HIV, because the commonest risk factor of lung cancer is smoking. And we all know that in HIV-infected populations, smoking is more prevalent. So that brings about the preventive strategy of smoking cessation and counseling for de-addiction in patients attending our ART centers. Coming to hepatocellular cancers, hepatitis B and hepatitis C co-infections account for a large percentage of our PL-HIVs. And you can see the contrast between the HIV-infected and the non-HIV population is very, very significant in terms of Hep B and Hep C co-infections. Hepatitis C and to a lesser extent hepatitis B augment the pathogenesis of hepatocellular cancer. But let us remember that hepatitis C infection predisposes to cirrhosis and cancers. Hepatitis B also predisposes to cirrhosis and hepatocellular cancer. So both are actually oncogenic viruses. Because of the epidemiological load is more with hepatitis B, we see more hepatocellular cancers which are hepatitis B associated. They are more likely to present with cirrhosis, more likely we're coming to hepatitis C, more likely to present with cirrhosis, more likely to be only moderately immune suppressed, and likely to have similar Barcelona clinic liver cancer stage at presentation. We will not get into this. Number one, because it is not in the domain of HIV medicine. And of course, number two, because of shortage of time. But it is the message again, or the take home from this slide is that if you have a PL-HIV who is Hep B or Hep C co-infected, you need to monitor for hepatocellular cancer. How do we do this? The next slide. Hepatocellular cancer can present as solitary lesion. Rarely in the domain of HIV, you can have multicentric hepatocellular cancer, and they can be resectable if the child PUG score is A. So basically, if there is no advanced chronic liver disease, you can have a resectable hepatocellular cancer. Liver transplantation appears to be superior to resection alone in HIV negative patients. And HIV seropositivity does not appear to be a negative prognostic factor for transplantation, meaning even HIV positive persons might be candidates for liver transplantation. If you need to remember one name, one chemotherapeutic agent, you remember sorafenib, which is again a tyrosine kinase inhibitor. It is well established in the management of hepatocellular cancer. The next slide. There are immunological and virological criteria which are necessary for considering liver transplant in HIV-related patients. We can glance through this because we are the persons who will consider eligibility for our patients who might be thought to benefit from liver transplant. No AIDS-defined opportunistic infections within the previous year. CD4 cell count more than 200 or at least more than 100 in case of therapy intolerance. Undetectable HIV viral load less than 50 copies per ml in the last 12 months, or effective therapeutic options for HIV infection during the post-transplant period. So basically, a person who is immunologically and virologically well controlled can be a candidate for liver transplant in HIV. The next slide. Recommendations. Coming to the guideline recommendations, alpha fetoprotein, as we all know, is a classical marker of hepatocellular cancer. And alpha fetoprotein screening every 6 months should be offered to all cirrhotic patients with HIV and non-cirrhotic PL-HIV with Hep B or Hep C co-infection. So basically, patients with Hep B or Hep C co-infection or patients with cirrhosis should have alpha fetoprotein performed every 6 months. Hepatocellular cancer screening with liver ultrasound should be offered to all PL-HIV with cirrhosis or decompensated liver disease. Hepatocellular cancer should be treated in the same manner as HIV negative persons. HCC in PL-HIV may be treated with liver transplant if feasible. And sorafenib may be used as a treatment option in inoperable cases of HCC. I think this is a very good and crisp summary slide of how to approach HCC in HIV and what to do with your HIV patients who are either cirrhotic or have co-infection with hepatitis B or hepatitis C or both. The next slide. I think possibly we are almost at the end of the presentation. There are a rising risk of skin cancers in HIV, which are non-melanoma skin cancers. Atypical features of HIV-associated squamous cell cancers are presentation at a younger age, unusual, some unexposed sites, including the mouth, genitalia, perineum, multifocal areas of involvement, aggressive and higher potential for recurrence and metastasis. Basically, we need to pay attention to local excision, good margin, more extensive surgery, more extensive investigations for dissemination of disease, and more intensive follow-up. The next slide. Basal cell carcinoma and squamous cell carcinoma. So these are the non-melanoma skin cancers. They have been reported to remit with antiretroviral therapy. We do not know whether this topical imiquimod has been used, but the response rate is not very predictable. The recommendations as of today are behavioral counseling to PL-HIV with fair skin to minimize UV radiation exposure and reduce skin cancer risks. Counseling on photoprotective behavior and sunscreen use. Interesting, we really don't do this in our clinical practice. Regular self-examination of skin and clinical skin examination. Early treatment of pre-malignant lesion is important to reduce skin cancer risk. The next slide. Penile cancer is also an entity which deserves a little bit of our attention. It is 5 to 6 times more common in HIV-infected people. Uncircumcised state, poor local hygiene, smoking, lichen sclerosis, and HPV co-infection are important risk factors. So, penile or genital ill health should be considered a risk factor, and there should be a low threshold for offering circumcision. So circumcision has been seen to be protective, and penile intraepithelial neoplasia and established penile cancer should be treated as per standard protocols. What are the recommendations? Counseling about genital health and hygiene. Routine circumcision is not advocated for prevention as of today, but let us remember that if there are high-risk features in the form of poor hygiene or lichen sclerosis or HPV positivity, there is a role for preventive circumcision. Examination of genitalia, and as I said, preventive circumcision might be offered. Smoking cessation appears to be important. The next slide. Friends, I really don't know whether I was able to do justice to this very large topic, because there are a growing list of cancers which are being associated with HIV. But as HIV practicing physicians and HIV treating doctors and nurses and counselors, I think what we should remember is very few things. Number one, cancers are a part and parcel of HIV. AIDS-defining cancers have been reduced with effective antiretroviral therapy. There are 3 AIDS-defining cancers: revise our discussion of the last 1 hour. High-grade non-Hodgkin lymphoma, invasive cervical cancer, and Corposis sarcoma. Despite antiretroviral therapy, non-age-defining cancers continue to increase, possibly because we are learning more and identifying more and more cancers in HIV-infected persons, and also possibly because our HIV-infected patients are living longer lives. Non-Hodgkin lymphoma remains the commonest. So when you get generalized lymphadenopathy or lymphadenopathy in HIV, think in terms of non-Hodgkin lymphoma. All lymphadenopathy in HIV is not tuberculosis. I think that is one line which should come at the end of this presentation. With aggressive variants more common, especially in poor immune states, so cancer screening is important, but also a thing which I did not mention, adult vaccination. Adult vaccination should be part and parcel of HIV management. So this is also important. And very importantly, clinical monitoring. We in medicine, we in ART centers, we cannot afford to say that cancer is not my cup of tea. I don't know cancer. I'm not an oncologist. I will not see cancer patients, because your HIV patients will not only come with HIV, they have always come to you with very opportunistic infections. And today, with HIV patients living longer, they are likely to come to you with a variety of malignancies. Thank you very much. And maybe there are comments or questions from the audience.
Thank you, sir, for the informative session. Please give me 2 minutes.
I think our audience have had enough of cancers over the past 1 hour.
Yes, so there are no questions in the chat box. Participants are requested to please unmute their mics if they have any questions, or they can even write in the chat box. I don't think there are any questions, sir. Thank you, sir, for this informative session. Thank you to all the participants for patient listening. We can end the session now.
Thank you very much.
Thank you, sir.